speaking of world leaders in addiction science, that's my perfect segue to introduce Dr. Nora Volkow, the director of NIDA and a long-term supporter of the mission of the college.
Good morning, everybody. It's a pleasure to be here. And again, happy Father's Day for all of the fathers that are here. And I don't like to just point one person, because obviously the work that we do is the effort of multiple scientists. But I do want to reiterate my thanks to Bill Dewey for everything that he has done, not just from the science, but also from the perspective of policy and for keeping us all in track. So, Bill, I want to applaud you again for everything that you really have done for the field. I also do want to reiterate the importance of preclinical research and basic science. And it's clear as we are moving into doing science in very different ways from the way that we did it, say, 10, 15 years ago. Research is much more integrative, and the ability to have preclinical models is fundamental in order to understand mechanistic findings in humans. It's also fundamental in terms of developing therapies early on, interventions, on understanding the mechanisms of those interventions. So I do think that it is fundamental that we bring up the opportunity at CPDD, both for basic scientists and clinical scientists, to work together, because after all, what is the purpose of a meeting like this one, but actually to strengthen our ability to do science, and you do that a lot through networking. So I do commend you, and NIDA will do everything that we can to help in that endeavor. I also want to thank my staff at NIDA, because you are all working and getting the grants and get all embroidered and how difficult these things are. But behind the scenes, there's a massive amount of work that goes and dedication from people that are extremely competent and knowledgeable and committed, but don't necessarily get the credit. So I'm going to take the pejorative and ask all of the NIDA staff that's here to please stand up so that people know who you are. And as you are here, I also want you, for those scientists, to reach out to the staff, because it's the way that we know what your priorities, what your difficulties are, and actually how we can help you. We need to hear from you, actually. Otherwise, sometimes you assume we know, but we really don't know. So thanks very much to my NIDA colleagues. And now I'm going to actually jump into the presentation, and I'm going to obviate everything that's going to go in NIH as a corporate, because I only have half an hour, and there are so many things going on right now in the substance abuse field that I became a little bit territorial, and I said I'm going to use the time for NIDA specific, basically related things. Though I recognize that there's a lot of work that is relevant that I'm not going to be mentioning. So these are the budgets, and you see the president budget, and this is my black slide, or darkness, as I'm actually mimicking George's terminology, the dark side of the budget. So this is the dark side of the budget, and we don't know how it's going to be. I mean, fortunately, our budget for 2017 actually was increased from what we were expecting. We were expecting at the most what we had got in 2016, and we got approximately a 3% increase. The increase for us is slightly less on the one hand because of the decreases that we've been getting on our funding for HIV as they change the priorities. We don't know, as I say, what exact budget would be for 2018, and we don't know. Whichever way the budget goes, of course, we will work with it and try to make the most that we can. In the Institute as an organization, several things, two very important ones have happened, very many things, but these are very, very salient. We finally were able to actually bring on board Rita Valentino as the director of our neuroscience division. Extraordinarily important. This hire was delayed because of all of the issues of the freeze and the change in the administration. So we are very, very lucky to be able to bring her into the Institute. She has a fantastic career track record, a very deep understanding on basic neuroscience and the interaction of stress and stress systems in driving drug taking. Unfortunately, we lost Phil Skolnick. Phil Skolnick went into private industry. We have brought him from private industry, and he gave us some very, very good years at the Institute, helped us advance several products into the market, but then industry took him back again. And we are actually opening, finally, we were given the green light to reactivate the search, which was put on hold because of the freeze. We're interested, of course, in someone with very strong knowledge on pharmacology. We want to be able to attract someone that has industry in pharmaceutical development, hopefully has worked in pharmaceutical industry that has been able to bring products into the market. So that you will start to see if they let us advertise. My last statement, like a couple of days ago, was that yes, Nora, you can go and open that search. And this search is going to be led by Chris Austin, which is the director of the National Institute for Advancing in Translational Science, NCATS. From the perspective of what are the subject topics that are actually enveloping almost everything that we are doing as a little bit of an urgency, though, of course, there's a basic research that is very solid, that is the backbone of what we do, but over it, we have these two issues that we have to address. The changes in marijuana laws on the one hand, and the other one is the opioid crisis. And now we have 28 states plus DC that have either medical or recreational marijuana. And of course, as one would have expected, having marijuana much more available and making it legal has changed norms, and people are actually consuming more marijuana than they were in the past. And you see there the regular use of marijuana, how it has been going up across basically all of the ages over there that you see, particularly among those that are 18 to 24 years of age. We were actually very concerned, as you know, and we all are, that something like this, the changes in normative perception of marijuana is not dangerous, would also result in an increase in the use of teenagers. Interestingly, what we have been observing over the past couple of years has been quite remarkable, as assessed by Monitoring the Future survey, which is a survey that goes into schools and surveys close to 45,000 children all over the United States. We've seen actually what is summarized in this slide, indicating significant decreases in green, that's what's good news, and significant increases in those drug patterns in red. And you can see that the landscape, whether we use the metric, they use three metrics, lifetime, past year, or past month. And we survey 8th, 10th, and 12th graders. To your left is the illicit substances, to the right is the legal ones. And both in the illicit substances as well as in the legal ones, we've seen very significant decreases in consumption among teenagers. And I think this is a remarkable process that's happening in our country that we did not expect it, particularly, for example, if you look at marijuana over there, which is in the third category into your left, you see that there are even decreases in 8th graders. Though what's notable about marijuana is that despite all of the drugs going down, this is the only drug that in teenagers has not gone down, basically for all practical purposes. And this is diagrams that actually illustrate the phenomena. So you have past month marijuana use, and you see the graphs is basically very, very stable. So 12th graders for past month is at 22.5%. And I want you to jump there to the cigarettes to the right corner, because the past month of cigarette use for 12th graders is 10.5%. So if you look at those numbers, we have double the number of teenagers that are actually smoking marijuana than tobacco, which actually reflects, I think, something that is not evident. And it is the dramatic reduction that we've been able to achieve in smoking among teenagers, which highlights in my brain the notion that prevention efforts, when done aggressively, can have a significant impact on behaviors that relate to drug taking in teenagers. Look also, not as dramatic as tobacco, but you also see a significant decrease in alcohol. And in the upper right corner, you see the other drugs that we've divided here by prescriptions and over-the-counter and illicit substances. And you can see actually into the left, the Vicodin, how dramatic the reductions have also been for a prescription opioid that used to be, when I came to NIDA, across sort of going between 10 and 11.5%. Again, a very, very strong campaign to actually target decreases in prescription opioid use by teenagers that actually has paid off since we brought it down. We were very concerned as the use of heroin is going up in the United States that we would see increases in heroin among teenagers. And so we were very positively surprised that what we are actually observing, like in the other drugs, is heroin use in the United States among teenagers, despite it being increasing everywhere else, is going down. So I think that the lesson that we take from here is actually what is driving these changes in the pattern of drug use in our country. And so there are several possibilities. All of this is speculative, of course. But one of the ones that we want to test, and we are going to be holding a meeting in October because it's something that as a science community we need to address, is since kids start to experiment as teenagers, and experimentation is a social process that is influenced by peer pressure, we want to evaluate the extent to which changes in social behaviors among teenagers, as have been brought by social media and wireless technology, have decreased the likelihood of teenagers to interact with one another, and maybe to what extent that may be a protective factor that minimizes that likelihood that they would experiment with drugs. Again, this is also very relevant because it is the adolescents as particularly sensitive to peer, and how this, through this social media, we could actually start to intervene in ways that could be beneficial and positive. The extent to which other reinforcers that come out of these wireless and video technologies are influencing alternative patterns is something that we also now need to understand much better. These are new technologies, so we don't have much knowledge on them. As you know, one of our priorities as the marijuana legalization came around, we wanted to understand, it's going to make it, and you see it, it's not going up on teenagers, but it's basically not going down like the rest of the country. The concept of actually to what extent the use of marijuana actually influences the developing brain. And we know that cannabinoids are relevant for neurodevelopment. They appear, cannabinoid, the endogenous cannabinoid system is actually expressed very early on in fetal development. And we know that it is relevant for a migration of neurons and formation of connections between neurons. So that's what sort of in a way had made these studies so very possible. And in the meantime, too, the Alcohol Institute and George coming on board, who also was very interested, and they had started to do a study in which they were evaluating with brain imaging the effects of alcohol consumption in teenagers. So we brought our brain together, the alcohol brain, the drug brain, and sort of says, let's do it. And the past is history. So we conceive of the ABCD study. Other institutes came on board. The ABCD study started recruiting in September. And as of now, there are 3,026 children that have been recruited and have completed the whole first evaluation. 400 or 600 of them, I don't know exactly how many because I don't recall, are actually going in the second phase of the evaluation. And there is an announcement that the data, the first release of the data with 2,000 participants will be made available and accessible to any investigators who want to take advantage of it. And I do want to thank both Dr. Susan Weiss and Gaia Dowling, who had basically done, and their team, who has really been extraordinary, as well as our colleagues from the Alcohol Institute and the NCI and IMH and ICHD that had worked very closely together to make this possible. And they actually came one day and says, Nora, we have data for you to show. And says, wow, you have already data. And so this is the data that they have on the analysis of the first 2,100 kids to actually document what the mental health parent report is and the mental health child report. Not surprising, we're seeing significant number of them already having ADHD. Again, highlighting how this study will allow us not just to understand drugs in a vacuum and alcohol in a vacuum, but how they interact with mental illness. And when I was looking at these slides, of course, it's not a big percent, but it still worried me. If you look at, for example, suicidal behavior among these children, it's approximately 2%, so it's not negligible. And if you look at it in terms of past suicidal behavior, it's actually, it goes close to 5%. And I think that this is, again, something that in the past we have not been able to do. Also, we will have a richness of data that will be valuable for the whole field. Again, this is an open access study for everybody to be able to take advantage of it. Now we jump into the opioid crisis. And the opioid crisis, you hear it, there are several reports every single day in the newspapers, and it does reflect what you have in here. This is the standardized number of people that die per 100,000 throughout the United States. Comparing in low levels, the lower numbers are in blue, and then the areas with very high numbers of overdose deaths, over 25 per 100,000, are in red. And those numbers in 1999 were only observed in 2 areas in the country, the center of Appalachia. I don't know if that's West Virginia or Kentucky, because I don't know my geography so well. But the other one is New Mexico. And in a period of 16 years, just look at what has happened. The overdose deaths have just gone almost everywhere. And you actually even have there in Alaska. And some areas, of course, have higher levels than others. And it does not follow on a one-to-one correspondence with the number of prescriptions of opioids as a function of the population. In some states it does, in others it doesn't. So this, I was seeing this slide for the 2014 data when Tom Frieden presented it in a meeting, and at that time what caught my eye was the second entry, New Hampshire, and I could not believe it. And he was presenting it differently, because he was presenting it from 2013 to 2014. And between 2013 and 2014, New Hampshire doubled the amount of overdoses, and that was actually what captured my imagination. Now, if you look at it, I want you to pay attention to the thing. These are 5 years, and this is the numbers of deaths in blue in 2010, numbers of deaths in 2015. Look at New Hampshire. Basically, it has gone from 11% to 35%. What is this? Okay. Death rate, no, it's not percent, death rate per 100,000. So from a very, very low, and if you compare it with other states in the United States, you had New Hampshire among the lowest one. Now it's among the second highest rates of overdose. And if you look at the deltas between those 2 years, what you can observe is that all of the states, the northern eastern states, are the ones that you're seeing those dramatic increases, including Massachusetts. That's to start with, had very high rates of overdose, because Massachusetts is a state where we've actually had one of the highest rates of heroin use. And I don't know why the slide is blinking at me. I'm getting upset for whatever reason. But so what is driving this notion of these large deltas? And what we are actually basically observing in this Northeast is a significant increase on reports of actually overdoses associated with fentanyl. In Massachusetts, actually, 2/3 of the fatalities from overdoses were associated with fentanyl. And you can see that in this, we've seen decreases in the number of prescriptions of opioids in the United States, which was what really initiated the epidemic. As more prescriptions were given to patients, this was easier to divert, and this resulted in abuse, and patients, some of them became addicted, and 4 to 6% of them transitioned then into heroin. This process made many individuals addicted to prescription opioids. As we have all been striving to actually educate physicians, to actually make it harder to get access to these medications, what we've seen is it has paid off slowly, but it's paying off in terms of decreases in prescriptions, but not in deaths. Deaths continue to go up. And then to continue to go up, to start with, we have not been able to bring down the trend of overdoses from prescription medications, but we are now seeing the consequences of that addiction to prescription opioids, the transition into heroin, and then the taking advantage of that market by the introduction of synthetic opioids like fentanyl, as well as other synthetic drugs with actually even a higher potency. And this is creating havoc. So you see the deaths in heroin, you see the deaths on synthetic opioids, fentanyl. These and other analogs, this is not therapeutic fentanyl. This is fentanyl that is presumed to be synthesized in illegal laboratories in China, that is coming in the United States through Mexico. And this drug is so potent, and you have it actually in here, into your right, that basically it is described as 100 fentanyl, 100 times, 50 times more potent than heroin. And there's been instances actually, albeit, and hopefully it stays like that, isolated 7 or 8 cases of death from carfentanil. Carfentanil basically is an anesthetic used for elements, extraordinary potent, with a very, very high rate for risk of overdoses. And so in the graph down, you're just seeing the number of requisitions of fentanyl. that actually indicates the expansion of the market of fentanyl in the northeastern part of the United States. We're starting to see it in other areas of the country, and this is very, very worrisome, because it's actually, there are also individuals that seek out fentanyl as the drug that they want. So it's not just the high levels of mortality associated with the use of the drug is not deterring some heroin abusers, which with lots of tolerance are going into that route. Look also at the price of heroin. The price of heroin has been reduced dramatically, and that also, of course, has contributed to why it is expanding. It's very pure. It's basically the purest we've ever had in the United States, and it's very cheap. So you have these two things colliding one with the other. And from the perspective of markets, of course, and supply, it's very easy to bring in drugs that you synthesize. You don't even need to grow a crop to extract it. You synthesize it. It's an easy synthesis, and the volume that you need to bring is very small. So I say this is going to be a challenge for all of us in the country as it relates to the emergence of new synthetic compounds that are going to be highly addictive, rewarding, and in this case, very toxic. So what is it that we're doing at NIDA? What is it that we're doing at NIH? And one of the things that basically now has come to the fruition, that this is actually, and the Secretary of Health, Tom Price, mentioned this, the opioid crisis, as among his 3 priorities. And the NIH also has embraced it as a priority for the NIH. And it's the first time in all of my time at the NIH that I have seen a director of the NIH embrace the importance of substance use disorders. And not just embrace it theoretically, but actively engage on working on it. So we have partnered in a strategy that can help us accelerate. Again, any strategy has multiple levels, but this one that we're right now focusing on, the first level, while NIDA does all of the work that relates to implementation research, as well as basic research in this domain, what is it that we can do to accelerate treatments rapidly that can help revert the overdose? So in science, there's the immediate rewards, the intermediate rewards, and the delayed rewards. And we always don't like to go just for the delayed rewards. But here there is an urgency, and we need to bring up things that we can mount up rapidly. So we are dividing, and this has been the strategy of NIDA all along. Now it's embraced by the NIH. The problem of the prescription opioid epidemic arose because of the need of patients with pain to have treatments and the limited availability of such effective treatments. So that had led to the over-reliance on prescription opioids. So the challenge is those patients are not going to go away, and they are very, very numerous. According to the IOM, more than 100 million Americans in a given year suffer from pain. And so how are we going to tackle that problem? Because if we don't tackle it, patients that have pain are desperate, and there would be a black market of opioids, and they will engage on misuse behavior if we don't provide with treatments. So what is it that we can do in the space of new medications that are opioid-based, that are non-addictive? What is it that we can do in new medications that are non-based on opioids? And of course, therapeutics that are not just based on medications. In the other 2 areas, how can we develop more easier to use, like what I want to call medications for the treatment of opioid use disorder, that will make it easier for patients to be compliant, that actually how can we bring other types of medications for the treatment of opioid use disorder? In no way am I critical of the medications. They are extremely effective, some of the most effective that we have, but we only have 3 classes. And how many classes of antiretrovirals do we have? How many classes of antivirals do we have for hepatitis C? How many classes of antidepressants? So I think that the reality that we need to treat substance use disorders as other conditions and demand for having higher alternatives. And finally, how can we do treatment of overdoses better? We have naloxone. We are extremely lucky to have naloxone. But now we're hearing that some of the patients are actually not being able to be reverted, that presumably they have some of these synthetic analogs that have longer duration, that the doses of naloxone are not sufficient to actually revert them. So this is another space that we're working on. And coming back to your point about the issue of the value of science in the whole field, for example, of pain therapeutics. I think that one of the most exciting areas, and this is relevant not just for pain therapeutics, but for the whole drug use field, is our understanding about intracellular signaling mechanisms of the G proteins. And in the case of the mu-opioid receptor, particular interest has arisen from the fact that dependent on the conformation of the mu-opioid receptor, you can activate, normally you are activating most of our drugs, presumably, both the G protein signaling cascade, but also the beta-arrestin. And there's data to suggest that the beta-arrestin pathway is associated with the side effects of drugs, of mu-opioid drugs, such as respiratory depression and tolerance. So the notion that you probably can develop a medication based on, now that we know the three-dimensional structure, that can bind to it and activate just the G protein without the beta-arrestin system to minimize the side effects, is now being tested by a drug, TRV130, there it is, that actually is undergoing phase 3 clinical trials for an indication of pain. If this is shown effectively to have much lower levels of side effects and similar analgesia, I would predict that this is going to energize the pharmaceutical industry to go into there. But there are many other things that we are pursuing, including the importance of the endogenous cannabinoid system as a mechanism that interacts with the endogenous opioid for the management of pain sensations. We're also working extensively, fascinating work in terms of how do we modify sodium channels, voltage-gated sodium channels. How can we get specific voltage-gated channels that may modify our sensitivity to pain? Another area that just, again, coming back to the issue of how extraordinary and fascinating basic science is the use of monoclonal antibodies to actually bind to signaling systems from the immune system that are responsible for pain, such as nerve growth factor, that is being pursued as an indication for osteoarthritis. And how can we learn from those actually to design other interventions? So the field is ripe with many targets that actually the big challenge is how do you bring this very fascinating basic science into the translational component so that you end up with a drug. And that gigantic value of that is a big challenge for us in the field as well as it is for pharmaceutical. But we need to bridge it because we do need better treatments. This is, again, to highlight the notion that, yes, we do have treatments that are very effective. And I said, well, we need to look, and we are funding a lot of research in NIDA funds for alternative treatments so that we don't stay static with 3 medications. But these medications actually have significant effect size in terms of outcomes that are relevant, including for the opioid crisis of overdoses. They decrease overdoses if you treat patients, and they actually prevent relapse, and they prevent criminal activity, and they prevent HIV, and they prevent hepatitis C infection, and it improves social functioning, and it improves the outcomes in neonatal abstinence syndrome. You name all of the categories, and medication-assisted therapy are actually significant improvement on outcomes, highlighting the importance of treating patients. But patients are not being treated, and I think that is, again, the other issue. So we are looking at the basic science, and I always say, well, basic science, here it is. What more data do you need? And yet it's not being implemented. And so that is, again, where that's why I say I'm very, very grateful from Bill to actually, where the issue of bringing this information to people that can make actually decisions, and now we have Berta here, who is in a very good, important position to try to bring forward the concept of science as a strategy that we can use to come to solutions. How bad it is? Well, you have the numbers there of how many receive treatments. I mean, how many do not receive treatment, 69.4%. But look at the cascade of care, and this is done by Ed Nunes and his colleagues, using the same model that is being used for infectious diseases. And what we want is patients, not just that you get 1 dose of buprenorphine and goodbye. We want patients to be retained in treatment, and the numbers there are almost non-visible. It's something like 2% or 3% that sustain treatment. So using metrics like this one will allow us to see how interventions, now we have money in the 21st century, are going to be improving these outcomes. So we can actually try to set what is it that we would want to achieve by applying treatment into individuals with opioid use disorder. But this is the current numbers are so low that if we aggressively institute treatment and sustain the treatment, we should be able to make significant improvements. So in this space, for example, since there are not so many treatment programs that can deliver the treatment, we're trying to take advantage of what all of the states have, healthcare systems. And the healthcare system is a great structure that we have that we should take advantage for in order to be able to screen and treat patients with substance use disorders. So we are deploying research at different levels of specialty. This is the data from D'Onofrio showing that an intervention, you get buprenorphine in the emergency department to patients, and you get much better outcomes that you send them outside. Now that we have, for example, medications that have extended release, and we do have Probufin for 6 months, but they are going to have, hopefully very soon, 1 week and 1 month buprenorphine administrations that will provide more leeway for those emergency department physicians to be able to treat in place. Significantly better outcomes. Look at this interim buprenorphine, which actually took the concept from interim methadone that was developed several years ago to create a delivery system that allows the patients to be managed from home. And look at the incredible outcomes that they get as opposed to those patients that are treated as usual, that are sent home because there's no place to put them in the treatment program. And then immediately, of course, they relapse. We know that story. But if you compare it with the interim buprenorphine versus those that don't, it's hard to see an effect size as large as that. And that's a 3-month outcome, highlighting the opportunity to expand this thing. And finally, the ability to treat in the criminal justice population is another low-hanging fruit that has been shown to be very valuable in multiple contexts. This is the data that actually was done by Chuck O'Brien and his team at UPenn, indicating how Vivitrol significantly improved the outcomes in patients that have an opioid use disorder over those that were treated as usual, where encouragement was given to give either methadone and buprenorphine. And to me, the other issue that's very notable is that overdoses in 8 weeks on this population was 7 in controls, 0 in Vivitrol. So as I was presenting this data and was speaking with Janet Woodcock at the FDA, I brought her up and says, could we once start to pursue an indication of a medication to prevent an overdose? And when you see numbers like this, actually this is very significant. You can actually, and she said that definitively that they would consider it. So we need to nail up the details, but it's an opening in terms of going from the only outcome that as of now has been accepted by the FDA, which is abstinence, to start to see, can we develop an intervention that can prevent overdoses? Again, of course, always the details are the ones that can determine if it goes or doesn't go, but there is an openness by FDA to look into this. And as I mentioned, these are, again, the low-hanging fruit. We're working extensively to try to make alternative formulation for these medications, partnering with pharma to do so that it's easier for patients to be compliant, and it's easier to treat patients in difficult-to-reach situations, such as many of the rural areas that are very, very negatively influenced by the opioid crisis. Naloxone, you saw us bring in partner again with pharmaceutical to bring the intranasal Narcan. Intranasal Narcan in pink is actually being taken up. And it's a very interesting, extremely important, because intranasal Narcan delivers the doses of naloxone equivalent in blood to those that you see when you inject it. And which is not the case for these improvised naloxone deliveries. This becomes, of course, fundamental when you're trying to bring someone from an overdose, because if you do not deliver naloxone rapidly and at sufficient doses, you're going to be unsuccessful. So one of the questions that people have raised, including the FDA, they brought it up to our attention, is just say the extent to which the failure to revert the overdoses from fentanyl may not be related to the fact that naloxone is ineffective, but that the way that it was administered may have been. And this is just data showing that the nasal Narcan, in fact, is very, very efficient in reversing overdoses. The space there, again, this is something that we want to be able, and I presented it in the past, we want to be able to track those individuals, and this is where right now focusing on patients that are high risk, that have pain, where we can actually monitor them to see when they are going to go into an overdose so we can intervene. Why? We don't know what the numbers are, but we do know that many patients overdose at night when nobody's around, when you cannot administer Narcan. So one of the research areas that we've also been funding investigators is auto-injectors of naloxone. So, and in the long range, the delayed gratification is biological treatments. And again, the challenges here are quite large because you are injecting a drug, so the concentration is very large, much larger than what you do when you have a bacterial infection. So if you are doing a vaccine, you have to have very high titers on the one hand, but very importantly, very, very high affinity. So there are several researchers working exactly on that, getting monoclonal antibodies that will provide with higher affinity. One of them is Kim Janda, and he had a very interesting paper where he actually been able to show that by delivering passively monoclonal antibodies, he can actually prevent the effects of fentanyl. And so we're working with that type of strategy in the long run to see if we could have alternatives that could protect those individuals at very high risk, long term. Immediately, how are we moving around to basically accelerate the development of medications? We've organized in partnership of Vice Francis Collins, actually, and really very much with is Francis Collins, who's sending the invitations, 3 meetings in a row, June 5th, June 16th, July 7th. 2 of them just happened. The last one was on Friday, and it was on how do we energize pharmaceutical to invest in medications for pain. The first one, how do we energize more of the pharmaceutical, and how do we facilitate the emergence of new delivery formulations, of new treatment for opioid use disorders, or prevention strategies for overdoses. And then the final one that hasn't happened is July 17, which is going to be more on the basic science and the component and the recognition that we really know relatively little about chronic pain, and in particular the transition from acute to chronic pain. Extraordinarily important. We all know that among those individuals, the higher risk of chronic pain are individuals that suffer for a substance use disorder. And we also know that patients with chronic pain are also at very high risk of comorbidity with substance drug use, including alcohol. And we also know that these individuals that have substance use disorder and that have pain are an extraordinary high risk of suicide. So here it is. We plan to move very, very rapidly. We should have a series of actions items so that we can hopefully be able, we don't know what the budgets are, but the idea is, again, to try to create some public-private partnerships in this space where NIH is going to, not just NIDA, be very actively engaged on it. And I want to end up with my slide because it's a pleasure for me to have been working the past 3 years so very closely with George Cook, who has been an incredible ally for the field all along before he decided to come to NIH, but he was also an incredible partner with the Surgeon General report of Facing in Addiction in America. And I do also want to point there to Tom McClellan, who also took a major burden in ensuring that the whole process moved swiftly and that it remained within the science in a way that would be impactful. And with that, I do want to thank you all of you for being here and for your work that you do for the Institute. And for the field, because it's not the Institute does it for the field. And I want to thank you again for the opportunity to come up and present priorities of NIDA. Thanks very much.